Good afternoon. Welcome everyone to the Senate Committee on Health and Human Services. Madam Secretary, please proceed to call the roll.
Senator Lang, Senator Wynn,
Here.
Senator Stone,
Yes, here.
Senator Titus, Chair Donate.
And I am here, and please mark Senator Lang present when she walks in. Welcome everyone to today's Committee on Senate Health and Human Services. Today we have a few agenda items. So for order of business, we will do Senator Hammond's bill first. Then hopefully by then we'll move on to Senate Bill 204, and then we'll save the work session for the end. So hopefully that establishes parameters, and just know that we might change depending on circumstances, but that's the plan for right now. I do want to share a few housekeeping items since we know that there are several bills that we will be hearing today. Again, agenda items may be taken in a different order than listed, and we ask that public comments be kept to 2 minutes each. If you have testimony for any of the bills today, we ask that you limit it to 2 minutes. And just as a reminder that if you go over the 2 minutes, you can always submit your testimony in writing to the committee staff. Anyone who wishes to receive copies of the committee's exhibits should go to the Nellis website. And last, let's make sure that we turn off our electronic devices and put them on silent mode. So at this time, I want to go ahead and open the hearing on Senate Bill 137. This bill requires that the state plan for Medicaid to include coverage for donor breast milk and certain related products. So with us, we have Senator Hammond. So Senator, please proceed when you are ready.
Good afternoon, Mr. Chair and members of the committee. My name is Scott Hammond. I represent Senate District 18 down in Las Vegas, and I'm here to present Senate Bill 137 for your consideration. I'm not going to speak too long. There's a lot of folks who would like to talk about this bill and the need for it. They're more, I don't want to say more passionate, but they are. They're very passionate people who have been working in this area for a very long time, and I'd rather have them talk. However, I would ask the chair if I could. I'd notice also that there are representatives here from the Department of Health and Human Services. One of the things I was hoping that they might come up and talk a little bit about, I know they're going to probably testify neutral on the bill, but there's about a year ago we went through a crisis where there was a shortage of milk for young babies, and I just kind of want to get their opinion on, what this might have done or what this might do in case something like that happens again, and just kind of get their opinion on that. But before I do, I'll tell you a little bit about the bill and what it does. It requires that the state plan include coverage for approved donor breast milk and human milk-based human milk fortifiers prescribed or ordered by a physician assistant, or advanced practice registered nurse for certain infants who require nourishment from breast milk. These infants that we're talking about, typically we're talking about somebody who is born 1,500 grams or less, and whose mother is unable to provide the breast milk that's necessary. What happens is if these young infants do not receive the nourishment that comes from the breast milk of their mothers, there's a lot of ailments that can occur. I know that there are plenty of people on the committee who have an understanding of this far more advanced than I have. But one of those conditions is necrotizing enterocolitis, which can affect their intestines. About a third of it is destroyed and requires a lot more health concerns later on. So this is one of those bills that I call a front-end bill, where we're actually trying to put money towards the problem at the beginning so that in the back end we don't have to spend as much, but actually a lot more money in their health care costs, because as they become young children, 6, 7, 8 years old, then you're talking about experiencing a lot more ailments, and you're talking about experiencing a lot more treatment in the hospitals or their physician care. And so that's what we're trying to do, is we're trying to take care of this problem on the front end instead of the back end. But anyway, that's kind of what this bill does. And that's, I'll just say that I'll let you read the language and ask questions. But if you guys have any questions, I'll be more than happy to try and answer them. If not, then we can get to some of the testimony. And obviously, some of the people who will be talking will talk about what they believe that this bill will do. And I think that's the most important part of this presentation, actually, is hearing from people who have been doing the work for a very long time and how this bill will affect what they do. So I'll just leave it at that.
Thank you so much, Senator Hammond. We will entertain the question that you have when we go to neutral testimony, since that's where we perceive that the department might speak. So we'll ask that question if that's fine with you. But at this time, I'll go ahead and ask questions to the committee members if they have any questions or concerns. Senator Titus?
So thank you for the bill, and certainly using a quote-unquote, the old term, a wet nurse, has been around for as long as mankind. So it's not unusual to have an assistance with human milk by something other than the actual birth mother of a child. My question is I'm not really too familiar with the process and if it's in other states, and what do they get reimbursed for this, and the actual prescription process. And so could you fill me in a little bit more on that?
Yeah, Scott Hammond for the record. I'll do my best. Yes, this has happened. Actually, they've passed this in several states, Texas being one. And I think you're going to hear from a hospital that there's a doctor from one of the hospitals. I hope she's here today. She'll tell you the success, what happened in Texas at least, and the amount of money saved by the state because of the process. Yes, the prescription is basically, for a variety of reasons, a mother's unable to give the nutrients, the nourishment to their baby themselves. And so they have donor breast milk, or they have a fortifier. And these fortifiers are a little bit different today. And the enrichment that they receive from them, not only the enrichment, but also the fortifiers that they put in there, puts them on the shelf, and they can keep them there during times where they may need them, as you saw about a year ago. I don't know what the prescription process is, and I'm hoping that somebody will be able to come in and talk about that a little bit today. But again, there's about 6 or 7 states that have done this now, so we're not the first, and I hope we're not going to be one of the last ones. But again, it's one of those where they have saved money. There's a savings that occurs, and it occurs in the back end because we put a little bit of money on the front end.
Thank you so much. Any other questions? Senator Stone.
Thank you, Senator, for bringing this forward. I think it's a very important bill. But I also would like to just kind of wrap my arms around the process of someone that is donating the milk. How is that done, and how do you ensure a chain of custody that the milk has been refrigerated, that it's not spoiled? Who has a liability for all of that? And then following up on my other colleague's question, is that donor paid something for the milk, and is that part of the Medicaid reimbursement?
Thank you very much for the question, Senator Hammond. For the record, if I just go direct, thank you. Yeah, so in some cases, yes, the donors are. Because you're dealing with 2 different systems. There are donor breast milk systems in place where the donor is not paid, and there is a system in place where there's a record keeping. But then there's also those who are paid for their donation, and that's mixed with a fortifier. But then again, these companies, there are several companies now that deal with this. One of them actually located in Boulder City, I believe part of your district. That company moved in a while ago, kind of had a rough start because of COVID and some of the other factors, and I believe they're back up on their feet. But I went through their process, and when they receive it, they document everything from the beginning until the end. It shows quite clearly where it came from, who had it, how long they've had it, and then, of course, and then when they put it on the shelf, how long it's good for. So there's a process in place for these fortifiers. They know exactly what's going on before they give it to the baby.
Thank you for bringing it forward. I appreciate it.
Thank you.
Thank you so much. Any other last-minute questions before we go? All right, let's go to testimony in support. So just as a reminder, please limit your comments to 2 minutes each, and speakers are urged to avoid repetition. And if you do get cut off, please submit your additional comments to our committee staff. We'll go to Carson City. Is there anyone that would like to provide testimony in support to Senate Bill 137?
Senator Jesse Wadhams with the law firm of Black and Wadhams, representing pediatrics today. Pediatrics is the largest provider of NICU services in the state. And not only that, I am a parent of NICU babies, having had both my sons in the NICU, one of which for 102 days. So the benefits of donor breast milk are you're going to see plenty of data about that, and I'm happy to provide more. But we stand in strong support, and I stand personally in support as well. So thank you.
Good afternoon. For the record, Tess Opferman here on behalf of the Nevada Women's Lobby. I'll keep my testimony brief, but we do understand, I think we all understand the importance of breast milk for the safety and health of our children, and therefore we're in full support of this bill. Thanks so much.
George Ross with Carrera, Nevada, on behalf of HCA, Sunrise, Southern Hills, Mountain View Hospitals, and Sunrise Children's. We strongly support this bill and urge your vote for it. Thank you.
Good afternoon, Chair Doniate, members of the committee. My name is Jimmy Lau with Ferrari Reader Public Affairs, representing Dignity Health St. Rose Dominican. We submitted a letter in support from the medical director of our NICU. St. Rose currently provides donor breast milk to NICU babies because it does, in fact, help with outcomes, and I'm happy to answer any questions. Thank you.
Thank you so much. Anyone else wishing to testify in support of this bill? We have, let's go to Las Vegas.
Good afternoon, Elizabeth Becker for the record. Thank you for hearing testimony on this bill today, Senator Doniate and members of the Senate Health and Human Services Committee. As a certified lactation educator counselor and a constituent of Senator Hammond, I'm in full support of this important bill in front of you today. I have been following this bill for several sessions and sincerely hope 2023 is the year we make these changes and ensure that all babies born in Nevada have access to the life-saving treatment that human donor milk can provide. This is a true nonpartisan issue. Any family could be impacted by a preterm birth and an extended NICU stay. Senator Hammond was my opponent during the 2020 election cycle, but he has always been a partner with the community on maternal and infant health care issues, and I'm grateful for his willingness to provide the best care to babies in Nevada. Approximately 45% of all babies born in Nevada are insured by Medicaid at the time of their birth. As you've heard this afternoon, many years of study have shown that infants in the NICU greatly benefit from being fed human milk as opposed to formula, and the rates of necrotizing enterocolitis can be cut in half when using human milk and human milk fortifiers. Many women are not able to provide their own breast milk to their infants for a variety of reasons, including medical trauma, preterm birth, and C-section complications, among many other factors. Donor human milk is readily available from over 30 milk banks in the Human Milk Banking Association of North America, and no baby, regardless of its financial status, should be denied access to human milk when a doctor has deemed it necessary. Many private insurance plans and TRICARE routinely pay for donor human milk, and Medicaid should as well. The cost savings from reducing stays in the NICU by an average of several days and reducing the risk for invasive surgeries that have lifelong, costly impacts cannot be overstated. I strongly believe that Nevada should follow in the footsteps of the 15 states and counting, including Utah, California, Illinois, and Texas, that already have laws directing Medicaid to cover donor human milk. Thank you for your time.
Thank you so much. We don't have anyone else in Las Vegas or Carson City, so let's go to virtual in support.
If you would like to testify in support of SB 137, please press *9 to take your place in the queue. Chair, there are no callers at this time.
Thank you so much. Next, we will move on to opposition. Is there anyone in opposition in Carson City, in Las Vegas, and BPS? Is there anyone virtually?
If you would like to testify in opposition to Senate Bill 137, please press *9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. And next, we will go ahead and move to neutral. Is there anyone in Carson City that would like to provide testimony in neutral?
Good afternoon, Mr. Chair, members of the committee. For the record, Marla McDade Williams, Deputy Director of Programs for Nevada's Department of Health and Human Services. I have with me Sarah Rogers, and as the Senator indicated, just provide some brief information about what a donor breast milk storage system might benefit for Nevadans. Thank you.
Thank you. Sarah Rogers for the record. So currently, as we know, Nevada doesn't have a human milk bank in the state. The Human Milk Bank Association of Northern Nevada did report a 20% increase in need to fill the formula gap during the formula crisis, as well as milk banks across the country saw a large increase in donations as well from individuals who are producing extra breast milk or maybe were experiencing loss or wanted to help parents fill that formula gap. They saw a larger increase in donations as well, with the Massachusetts Milk Bank reporting an increase from 30 to 50 donations per month to about 30 per day during the formula crisis. So right now there are only 3 milk depots in Nevada where women can go to donate their breast milk to these licensed milk banks, the closest one being San Jose, which our depots work with. There is 1 in Washoe County currently and 2 in Clark County. So having 3 in the state does produce a barrier for a lot of women who may be interested in donating breast milk, and it is always shipped out of state to San Jose for processing and can be distributed as needed to other locations that the San Jose Milk Bank does serve at this time.
Thank you so much. Is there anyone else in neutral for this bill? Anyone in Las Vegas, BPS, anyone else virtually?
If you would like to testify in neutral for SB 137, please press star 9 now to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Senator Hammond, did you have any closing remarks?
Thank you, Mr. Chair. I'll be brief. I can't let the moment pass. You know, when you have a long career, and sometimes 2 years seems like a long time, but 12 years, 14 years seems a long time. This is one of those milestones in my career because, 1, I'm passionate about the bill, but 2, the fact that I had somebody who ran against me come and testify in a bill where we can sit down and say, you know, both of us say this is really important for our community. I can't let that moment pass. I wanted to say something about that. Thank you to Elizabeth Becker for taking the time to come and talk about it. There's just 2 people that live in a certain area that are passionate about something that can affect their community. I'd like to thank the other folks who took their time to come and support as well. And I appreciate it. If there's any other questions offline, I'd be more than happy to take them. Thank you.
Thank you so much, Senator Hammond. We appreciate you for bringing this forward, and we hope that we can continue to work on this legislation. So at this time, I will go ahead and close the hearing for this bill. We're going to move on to Senate Bill 204, and at this time, I will go ahead and pass the gavel to Vice Chair Nguyen.
Good afternoon. At this time, I will open the hearing on Senate Bill 204. Senate Bill 204 provides for the limited practice of medicine by certain medical school graduates. And I will welcome our chair to the hot seat, and please begin when you're ready.
Thank you, Vice Chair Nguyen. I'm going to go ahead and begin my remarks, and hopefully the PowerPoint presentation virtually can get going as they share their presentation, but I'll start my remarks. So again, thank you, Vice Chair Nguyen, and good afternoon to the members of the Senate Committee on Health and Human Services. For the record, my name is Fabian Doñate, and I represent Senate District 10 in central Las Vegas. Today I come before you to speak on Senate Bill 204, which provides for the limited practice of medicine by certain medical school graduates. Today, I am joined by Mr. Anthony Anguille Valles, who is a medical school graduate from Touro University and a current student enrolled at the UNLV Boyd School of Law. Before I let Anthony present on the bill language and the two sections of the bill, I want to document for you my rationale for bringing this important legislation forward and why we desperately need solutions now to welcome more physicians into our state. As many of you know, outside of my capacity as a legislator, I work as a health administrator. During the interim, I had the chance to run medical facilities with varying levels of practitioners, and I oversaw the general operations of a health center that served parts of Las Vegas. Given my personal background as a health administrator, I fully understand the barriers that we see on the front lines of our healthcare system. Let me be clear. We have a severe shortage of medical workers, period. We see this in every profession of folks in the healthcare sector. And during my tenure as a health administrator, I faced devastating circumstances and difficulty recruiting medical professionals to work and apply for the open vacancies in my facility. From a personal capacity, I distinctly remember having a vacancy for a physician open more than a year. And my goal was to find at least someone who was bilingual and practice family medicine that could speak and communicate in Spanish, and we faced difficulty even finding that candidate for that right role. To paint the narrative for you on how severe this shortage is, to get on the schedule for my primary care provider, you would have to wait at least a month and a half before you get an appointment. Last year, in my early discussions with community members throughout the state, it came to my attention that we have residents currently living in this state that have the knowledge and experience to practice as physicians. And whether they're international medical graduates or students that haven't matched into a residency program and want to practice in the interim, I believe that we could do a better job to pass common sense policies that welcome these individuals to our state. The only problem that stands in our way is one thing, and that is how our laws are written. From my personal perspective, I believe it is our responsibility to ensure we have every tool at our disposal to attract more physicians to our state. Whether they're international medical graduates seeking to obtain licensure or our very own students that don't get matched into a residency program, we need better tools to allow more individuals to fill the voids that we are experiencing in our community. In general, with respect to this bill language, I firmly believe that as long as these individuals meet the clinical and quality metrics established for our physicians and the requirements set forth through medical training, there should be pathways for individuals to practice medicine. And at this time, I will go ahead and pass the mic over to Anthony, who will go over his personal story, the background of this bill, and the proposed amendments that we have documented for this bill thus far. So just to let you all know, so Anthony is incredibly brilliant. He is a graduate from Touro. He came to me with a simple proposal, which was, how can we fix the shortages that we saw from the COVID-19 pandemic? What can we do to strategize and come together? And so I want him to document just his personal story, and then we'll walk through the bill language and the proposed amendment.
Thank you so much, Chair. I will be frank that brought a tear to my eye. I am an empath. This bill, of course, it came to you sort of in this simple idea: how can we fix an issue that continues to affect all Nevadans, whether rural, whether urban, whether of one political party, another. This is an issue that we both agree has a common sense solution, especially within the bounds of what the Nevada Legislature is capable of doing. So with that said, I would love to share a little bit about myself. I don't want this to be about me. I do want this to be about Nevadans. And I believe that that is what the committee is here to do. I believe that that is what Senator Doñate has chosen to do with this bill, is that we want to influence change in a way that affects everybody, regardless of partisanship. And that's why this is a logical bill. So with that said, my name is Anthony Angeli Valles. Of course, I am a doctor by training, a doctor of osteopathic medicine to be specific. I graduated from Touro University, California in 2017. But before that, I genuinely am a Nevadan at heart. I've been here since the year 2000, intermittently, of course, because medical training takes you everywhere. So I've been all around this beautiful country, but at the same point, Nevada always has a way of pulling you back in if it is true to heart. So with that said, I graduated from Coronado High School in 2005, valedictorian of my class. I graduated with my bachelor's degree in psychology from UNLV in 2009. while experiencing a burgeoning hospitality career in the spa industry on the Las Vegas Strip. Went to medical school in 2013, graduated in 2017. And where does my story go? I did very well in medical school. I am in many ways the antithesis of some of the stories that you'll hear about why people don't match, which there are myriad reasons behind why people do not match, and why the system is currently not capable of offering or affording all of us the opportunity to practice within our training. So I applied to be a urologist. I went through the AUA match, which was at that time, I think, the only specialty that had a separate match. I did not match, unfortunately, into the very few programs to which I applied. I then scrambled into a position in a residency program in family medicine, which was heavily inpatient focused in Chicago, Illinois, and found that that program was just simply not for me. What are your options as a fledgling medical school graduate at that point? You can stick with your program and sort of see the end goal in mind, or you can attempt to take the bull by the horns and say, you know what, this isn't the future that I saw for myself. And it wasn't the future that I saw for myself. That wasn't the right program for me. That wasn't the training that I was seeking that was most amenable to my future. So I went back to hospitality. I left my residency in good academic standing. I had no professional disciplinary measures against me, nor any concerns expressed. And I ended up falling into the legal field. And I am beyond blessed with the opportunity that William S. Boyd School of Law at UNLV has afforded me. It's a second chance to give back to my community and hopefully provide services to people in a way that that I feel that my heart allows me to do so, as well as my training. So I will be graduating from law school in May of this year, and to have this experience with Senator Doñate to present this to all of you, it means the world to me. And with that said, enough about me. I would love to discuss the bill and going to give you basically a short overview of some of the background that went into my research that Senator Doñate, of course, has reviewed and heard from me. But additionally, I will touch on some of the amendments that are now part of the exhibits. So please feel free to reflect on those as I discuss those after this introductory piece. And then I'll give you a few short takeaways, me as an advocate for the record, and why I believe this bill is not only logical, but necessary under the current circumstances affecting Nevada. So the background. Essentially, I will mirror what Senator Doñate has said and try and minimize the repetition per his direction. But as we currently understand it, all of Nevada's 17 counties are presently recognized as primary care health professional shortage areas. Those are designated HPSAs. Further, a subsection of those are designated medically underserved areas or as housing medically underserved populations. These are federal designations. They look at a number of different statistics, but essentially are looking at population to provider as well as some socioeconomic factors. So what this basically means is the entire state of Nevada is basically on the precipice of potential public health emergency, not having additional influx of medical providers to provide care that they require in the immediate. The COVID-19 pandemic, although I'm sure we are all largely frozen in time, not wanting to discuss this anymore, there is a reason we have to touch on COVID here, and that's that COVID manifested some of the health disparities that are affecting the rural regions as well as many of the urban regions within the state of Nevada. COVID specifically affected those who are living with chronic illness. Those with chronic illness are the most likely not to have access to primary care. And those with chronic illness, when they contracted COVID, they were more likely to suffer severe disease, if not death. So sort of drawing the correlation between all of those items, it's very clear that increasing access to care is of the essence in ensuring that we do not leave both our rural communities and our urban communities at risk of a potential future pandemic. Something else that COVID did, it encouraged a massive influx of populace into the state of Nevada. We are an optimal destination for so many individuals, especially in an era where technology has afforded the ability for all of us to work remotely, well, for many of us for that matter. But with that said, that is all against the background of quiet quitting in the medical profession, including doctors. So while there may be a number of doctors still maintaining their practices. Many of them have cut back on the amount of patients that they're seeing, and likely for good reason. They've gone through some of the most stressful periods in their entire lives trying to afford care in an absolutely unparalleled public health crisis. And so what this means for us is more populace, less access to care, immediate need to increase that number. And that's what this bill serves to do. I would like to highlight in 2013, what did Nevada do? The legislature granted full independent practice rights to nurse practitioners. That was very much against a similar backdrop, but certainly one that was not amplified by a public health crisis. That has not met the initial, the increased demand that we are seeing here sort of jurisdictionally. So moving forward, I'm now going to go through each of the sections with you as briefly as I can. So beginning with sections 1 through 5, and I want to sort of introduce this concept to you. In Nevada, the way that the law is presently written, we have sort of one section that addresses the MD physician, as well as physician assistant, perfusionist, et cetera. And then there's also a separate chapter, that's chapter 633, that addresses osteopathic medicine. So the reason that you'll see duplicit sort of two sections addressing the exact same subject matter is because there is a section specific to the medical profession, the MDs and the DOs, and that's why you'll see this sort of repetitious aspect to my presentation. So Section 1 addresses the fact that sections 2 through 13 are going to apply to that MD specific chapter, which is the chapter 630 of the Nevada Revised Statutes. Section 21 will do the same thing, reflecting on the amendments that, the changes to the legislation, the changes to the current statutory scheme that would be provided by the Act. Sections 2 and 22 define in the exact same terminology what the Act defines the medically underserved area as. And essentially that's going to take into account those federal designations of health professional shortage area, medically underserved populations. Sections 3 through 5, while I will not heavily focus in on this section, it is largely analogous to what I will be discussing today in terms of requirements, expectations. But sections 3 through 5 specifically provide for the Nevada Board of Medical Examiners to recognize limited licensure for certain foreign medical school grads. Those medical school graduates are those certified by the Educational Commission for Foreign Medical Grads. They have to have passed their United States Medical Licensing Exam Step 1 and Step 2 CK. You'll see that it's a through thread here into the domestic medical school grads as well. And the term expected of these limited licenses is 2 years. That again will be a through thread of the other pieces of this legislation. The limited licenses in all regards will be under the supervision of an unrestricted licensed physician. That is largely without contingency. I'll speak to one exception to that rule very shortly, but essentially in all regards, these limited licensees will be serving in a mid-level capacity in this sort of collaborative mechanism that Senator Oñate referred to, working with a supervising physician to provide care to those most in need. So sections 6 and 23 are those that actually delineate, both for the Board of Medical Examiners and the State Board of Osteopathic Medicine, what they're authorized to do in terms of issuing a limited license to the associate physician or the associate osteopathic physician. This applicant, whether it is the associate physician or associate osteopathic physician, they will have had graduated from medical schools in the United States or Canada. When I say certain medical schools, essentially those that have been accredited by the LCME or COCA, or those deemed equivalent by the board. They will have agreed to practice in a medically underserved area. That's very similar to our foreign medical school graduates who have to have committed to at least 2 years of service. That's one of the amendments that I'll touch on later, but that is a requirement for them. Number 3 here is that they have had to pass Step 1 and Step 2 CK of their USMLE or the osteopathic equivalent, so being COMLEX in this case, or again, exams deemed equivalent by the respective boards within 3 years of licensure. That's important to note because this is, again, taking into account the fact that we also have to protect Nevadans to ensure that Nevadans are receiving care from those who are up to date on many of the different changes in the medical community and the and what those health policies are. And of course, they have to be proficient in the English language to provide care to a nation that still largely recognizes that the English language is the primary language of the nation. Section 7 and 24 are then going to lay out, again, some of these considerations, wanting to ensure that we are protecting the populace and making sure that the AP and the AOP, I'm going to use those abbreviations here forward, but essentially those mid-level providers are going to be providing care in those areas that we most need them. So specifically primary practice areas, family medicine, pediatrics, internal medicine, psychiatry, obstetrics, and gynecology under the supervision and control of a fully licensed physician with an unrestricted license under Nevada law, practicing also in that medically underserved area. And this is, again, key, pursuant to a collaborative practice agreement, which there's very much the same analogy within the physician assistant legislation that presently exists in the Nevada revised statutes. So for the first 30 days of practice, the supervising physician will be required to be physically in the exact same premises as the associate physician or associate osteopathic physician and available at all times while they are providing patient care. The associate physician working in a rural health clinic shall be considered a physician assistant for certain federal purposes. And I want to highlight this and why I keep bringing up physician assistants, nurse practitioners, other mid-level providers. We first of all want to recognize that this is the intent of this bill entirely, and that's that we are creating a mid-level capacity to serve as part of this team. But for our purposes, much of this legislation should mirror what you already understand as to what physician assistants are capable of doing under the law as it presently exists. Sections 8 and 25 are very important for public health purposes as well, in ensuring that the public understands the varying levels of training of the medical professionals to whom they see or who they seek care from. So here, this is basically delineating what the associate physician, associate osteopathic physician must do in terms of letting the public know that that's the capacity that they're serving in. They will be allowed to utilize the term doctor, which of course immediately you say, well, that doesn't, explain to them what their level of training is. But at the same point, that's also the same right that we afford our resident physicians immediately into residency. They are allowed to designate that they are doctors, but where we protect the public is in ensuring that the clinic itself has posted signage that very much indicates that there are different levels of providers available, and that if they are to be seen by the associate physician, they may request to be seen by the supervising physician. The supervising physician and the AP at all points will designate that those are their positions with physical badges designating such. Sections 9 and 26 are specific to the supervising physician, and this very much overlaps with what I've already said, but they are responsible for the mid-level provider serving under their license. They are required to carry liability insurance covering the malpractice for any of the services provided or rendered by the AP. And it does limit the supervising physician from entering into collaborative practice agreements with more than 3 APs or AOPs. Why? Because we want to ensure that they have the ability to continue to have the focus on those individuals they're supervising, to continue to allow them to gain the experience they need to be that much more successful and more have the larger capacity to treat a much larger swath of ailments. Most importantly, for those who are going to be taking the supervising role, this Act would also prohibit the Board of Medical Examiners or Board of Osteopathic Medicine from disciplining the supervising physician for any legal activity performed by the associate physician within the scope of the collaborative practice agreement. I won't go into depth heavily on this, but essentially sections 10 and 27 are going to lay out what the collaborative practice agreement looks like, what needs to be in there. And this is basically going to shape the relationship between the supervising physician and the associate physician. There is an amendment to this section because we did note that this was a largely overly detailed in terms of what went into statute. And we wanted to basically delineate who was going to be responsible for how the collaborative practice agreement came together. And we're largely going to be moving that responsibility over to the respective boards. And that's exactly what we see under the physician assistant currently existing statute. Here's that exception I talked of earlier. When can provisions of the collaborative practice agreement be waived? specifically in the rural health setting where the supervising physician is practicing in a rural health clinic, they may waive any of the provisions of the collaborative practice agreement for not more than 28 days in a year. And there's an amendment to this as well, provided they are available via certain means of communication while the associate physician is actively providing care to patients. Sections 11 and 28 speak about associate physician, associate osteopathic physician prescriptions of controlled substances. Physician assistants under the law are able to prescribe in the same way. So essentially the collaborative practice agreement will largely delineate what kinds of controlled substances the AP is allowed to prescribe pursuant to that agreement. And then there is an amendment to the act that also provides the Board of Pharmacy additional ability to limit the prescription of controlled substances pursuant to their review and subsequent issuance of the registration certificate. Sections 12 and 29 provide for expiration and renewal. Again, similar to the foreign medical graduate portions of this bill, sections 3 through 5. These licenses will expire after 2 years. They are renewable, provided the associate physician can prove or provide proof to the board that they practice pursuant to a collaborative practice agreement over the course of the previous 2 years. There is not currently a pathway into unrestricted licensure for the associate physician or associate osteopathic physician. That's not the intent of this bill. And in the foreign medical graduate capacity, though, that is written into the initial form, that is also going to be addressed here shortly in the amendments. Sections 13 and 30 are then going to require the State Board of Osteopathic Medicine and Board of Medical Examiners to adopt regulations to ensure that all of the provisions of this act can actually go into effect. So what these sections actually delineate, that the respective boards must adopt regulations to carry out the provisions of the act. They must work with medical schools in the state to develop and implement a program enabling the associate physicians to gain knowledge and experience that may count as residency credit, and also to require both of the boards to maintain a website whereby members of the public can also see who is serving as a supervising physician and who is serving in the role or capacity as an associate physician. The other sections of the bill that I've listed here largely are conforming changes, sort of structural changes in the act, where associate physicians would also need to be included in sort of a list of medical professionals. But the most important key provisions here that I'd like to address are sections 37 through 40, 42, 43, 45 through 48, and 50, all of which require insurance companies within the state of Nevada to provide coverage for medical services performed by associate physicians, including Medicaid, to essentially ensure that services that they render are going to be covered. And this is basically at a rate commensurate with physician assistants under the law. And section 49, you'll note the Commissioner of Insurance will be authorized to take certain action against those health insurance companies that do not comply with the aforementioned sections. So on that, I greatly appreciate your patience. I know that that was highly detailed. I would like to go through the amendments with you. I'll do this very briefly, and I've sort of already touched on a number of them. Starting with section 3, we did modify, there was a, this is in the foreign medical graduate capacity, there was an initial, the initial language required that they commit to 3 years of practice in a medically underserved area. We modified that to 2 years to be in line with the duration of these licenses. So their requirement is that they're committed to 2 years of serving in medically underserved areas for that 2-year time, which is the duration of their license. Section 5, this removes the, we elected to remove the pathway to unrestricted licenses for foreign medical graduates. So that has been conceptually removed from the act and certainly open to discussion. Section 10, we removed the express provisions regarding how frequently supervising physicians are required to review the standard of care of the associate physicians. This is because we wanted to allow the board that opportunity to basically express that in the Nevada Administrative Code. They're going to be the ones to adopt the regulations in terms of how to how often the supervising physician will be required to review medical records to review the standard of care provided by the associate physicians under their license. That's also section 27 in the osteopathic realm, so NRS 600, excuse me, NRS 630 to NRS 633. Section 10 and 27, we just added verbiage while in the course of providing patient care. The way that it was written, this is the contingency whereby in the rural health clinics, a supervising physician may waive the provision, waive any of the provisions of the collaborative practice agreement. We didn't want the supervising physician to be on call every moment of their lives. It seems highly unrealistic. So we wanted to obviously clarify that this was while the AP was actually practicing and providing care. So essentially their work hours. And then section 34, this was a section that's specific to NRS 633 under the osteopathic section of the Nevada revised statutes. There are a number of provisions in the statutory language regarding continued medical education where they include osteopathic physicians and physician assistants, and we wanted to ensure that associate osteopathic physicians were included in that language, largely in the conforming fashion that you saw under sort of that last slide. Section 51 was added. So section 51 was formerly the section that basically allowed all of the former sections to be adopted and when they were essentially law. We moved that section to section 52, but section 51 actually is the section that we added in to authorize the State Board of Pharmacy to further limit the prescription of controlled substances, poisons, et cetera, pursuant to their issuance of the registration certificate that's required of certain medical providers, including physician's assistants and associate physicians. So those are the amendments. I want to leave you with two takeaways, and I genuinely appreciate the time you've given me thus far. I know that this is beyond many of the comments that you'll receive, but two main takeaways for me. Number one, this is not a referendum on graduate medical education. We are overwhelmingly respectful of what training graduate medical education institutions afford medical graduates. There is a learning curve, an experiential learning curve that is unparalleled. And that is why those that graduate from residency programs are able to go out and practice as independent, unrestricted licensees. This is not the capacity we're seeking here. And there is sort of this through thread of, well, shouldn't we be investing in graduate medical education? This bill does not disagree with that concept, but we also have to address the issue that's immediately before us, and that's the acute issue. I'm going to call this sort of the acute on chronic to make the medical analogy. We have a chronic issue of a lack of access to care in Nevada. The acute issue on that chronic issue is the fact that this lack of access to care was deeply amplified by the COVID-19 pandemic. Before we can address the chronic issue, the issue that I believe is addressed through continued funding and increased access to graduate medical education programs, we must address the acute issue before us, which is the need for primary care access now. Those in the rural communities, those in the specific urban communities, they require healthcare now. They can't wait the 5 to 10 years that would be required of the state of Nevada to work with the federal government and CMS to increase funding, to increase access to these programs. We believe that both issues need to be addressed, but they can be addressed in tandem. My last point, it ties back to this discussion of the collaborative practice sort of model that Senator Doñate works in, that he espoused in his testimony on behalf of the bill. We want to afford those with requisite training to actually provide the care that they are capable of providing. That includes medical school graduates who I absolutely agree have a learning curve ahead of them. But that learning curve is no different from the learning curve that physician assistants have when they leave physician assistant school. That learning curve is no different than the learning curve that nurse practitioners have when they graduate from nurse practitioner training. But remember, the difference is that physician assistants and nurse practitioners who numerically have less training both clinically and preclinically in the substantive and experiential components of their training compared to the medical student who's graduated, they are able to practice when they leave school. This bill affords that same ability to the medical school graduate who, for any number of reasons, cannot complete a residency program. And with that, I greatly appreciate your time and thank you again.
Thank you so much, Vice Chair Nguyen, Fabian Oñate for the record. So again, I want to refer the committee members to the amendment that we have proposed in the bill irregularities, which can be found on Nellis. There are several other attachments on Nellis that I would like to point out to you. We have a really good testimony from Dr. Ostavar Kermani, who many of you know. There is a school of medicine in Guadalajara, and we have students, particularly Nevada residents, that fall into the same circumstance where they go to school outside of the country, and when they return back, they don't have the ability to practice medicine. And that's something that we're going to discuss, of course, with IMGs. And we received a report today that is also on Nellis. It's from the American Immigration Council. It's about the growing demand for physicians in Nevada. Between 2018 to 2022, in general, we saw a 12.7% increase in job postings for physicians. Whether with general internists, that was about a 45% increase for these jobs postings. When you look at the example that I provided, right, where I was putting a job application as part of my health facility for someone that was bilingual, from 2018 to 2022, the number of healthcare job postings that required bilingual skills in Nevada increased by at least 28.6%. And when we talk about brain waste, which is the term that we use where the skill sets of these immigrants who are here and can practice and have the knowledge, but are often underutilized, leading to underemployment or unemployment. In 2021 in Nevada, 34% of immigrants with professional and doctoral degrees worked in occupations in the healthcare industry that did not require those degrees. So I think it goes to the bottom line that whether we're looking at the international medical grads or the student like Anthony that could be afforded the opportunity to fix the shortages that we have an opportunity to address it. And one thing to make clear for the record, this bill does not change any of the credentialing requirements or the processes set forth by pre-existing contractual agreements by our healthcare payers and providers. My ultimate goal is to fill the shortages that we're experiencing, and I do not want to circumnavigate the processes that we have in place. They are not part of this bill and should not be modified, in my opinion, to severely limit it. So with respect to billing, reimbursement, supervision, our goal for the associate physicians is to establish guidelines the same way that we approach for physician assistants. And at this time, I'm happy to answer any questions from the committee members and with respect to the bill language, the amendment, and Anthony's as well as is available for any questions.
Thank you. I just have a question, I guess. First of all, I wanted to thank you for bringing this. I think if anyone knows you and has worked with you, they know that you care deeply about the shortages in the healthcare system and are always looking for creative ways to alleviate some of the stress that our community is feeling by these shortages. With that being said, I know I just kind of briefly looked around the country to find out whether or not that we have this type of practice in other states, and I was wondering if you could expand on that.
Thank you so much, Vice Chair Nguyen, Fabian Oñate for the record. I believe your question is referring to the associate physicians. Anthony, did you want to go ahead and touch more on that?
Yes, I would love to, and I greatly appreciate that question. And that's largely what went into my policy proposal was my research in this area. So this was initially legislation that took hold in Missouri. I believe that officially was enacted in 2017. They were largely dealing with very similar sort of healthcare professional shortage, both in the rural and in the urban regions. So they adopted legislation that is very much analogous to the legislation that you have before you. Other states have followed suit, and that's largely with substantial sort of opposition from a number of different networks to fill these same voids. So other states that have followed suit in some iteration of the same sort of form are Kansas, Arkansas, Arizona. I believe Washington is in the process. Arizona has enacted something very similar, and Utah. So we would still be in the minority of states, but this is something that is ever burgeoning sort of jurisdictionally, because all states are largely dealing with something very similar to this. This is not only a Nevada issue, but also a domestic issue.
Thank you. And just to follow up on that, you said that this language kind of emulates the more, I guess, substantial program that was enacted in Missouri. Or is this like a version of this? Because it sounds like in some of those other states where it has been enacted, it's maybe not as comprehensive as what we're proposing here in Senate Bill 204. Is that correct?
Yes, it is. It is exactly what I was essentially saying. So Missouri's act, in some ways, is actually even broader than our act. That largely, there's these minor differences, largely with the requirements for an associate position. Something like they are only required to have passed step 2 or COMLEX level 2 within the 3-year time frame before they've applied for licensure. So they're not requiring both sets of boards. It's a very minor difference, but essentially one that does have impact on who would actually be able to do this. But what happened in those other states, sort of after Missouri was able to innovate in this realm, was you saw the initial act get presented in the same form that you're seeing it in ours, essentially, and then have whatever the legislative process did in those respective states to basically draw it down to a bare minimum. So I'm going to give you some examples, but let's speak about Arizona, who are the most recently to enact something very similar. Their initial legislation is largely what we are seeing before us. What they ended up enacting was a limited license to medical school graduates in Arizona who were then able to practice in this sort of mid-level capacity for 1-year terms for, I believe, a duration of 2 years maximum, basically giving them time to reapply to the match. So what you saw with those pieces that were actually sort of drawn down was they narrowed the scope of who could actually utilize this and, sort of utilize their skills in the interim, but they weren't addressing the primary care shortage as much as they were just giving medical school graduates an opportunity to do something while they reapplied to the match. That's not the purpose of this bill.
Thank you. And I think I have a question here from Senator Titus.
Thank you, Madam Chair. And again, thank you for bringing it forward. I appreciate all the effort that both of you put into this. Senator Donate, I appreciate your engagement with me and my questions and my concerns and the modification that you did over in those. Obviously, I still have some concerns and questions. First, just about numbers. How many medical school students do we graduate a year, MD-DOs, and how many residency slots are there?
Thank you so much, Senator Titus. Are you referring to the state of Nevada, or are
I'm
you?
talking about nationwide. How many students do we graduate nationwide from medical schools, MDs, DOs, and then how many possible residency slots are available?
Anthony, do you want to touch point on that? There's also a statistic as to how many go unmatched.
So Senator Titus, thank you for that question. I did some research on this today, anticipating a very similar question to that. I don't have the statistics in front of me. I'll be absolutely truthful, but I'm going to be able to speak in generalities that I think will still address your question. What we are seeing statistically, there are about 42,000 applicants, those that are actually participating in the match. We should see new match statistics here at the end of the month. At the end of the month, we are now in match month, as you are certainly aware. So what we're seeing statistically are approximately 92% of MD graduates domestically will match, 91%, give or take, of osteopathic medical school graduates are not are matching. So that's leaving about an 8 to 9% gap. What does that equate to in numbers? That's about 3,000, give or take, in each of those areas. So about 3,000 individuals who graduated from MD programs or DO programs in each of those areas, so 3,000, that are not matching each year. And what's important to understand about that is that that number is now piling, right? So we have a number that's sort of building on itself. Of course, the medical school graduate can reapply to the match the year after. But what statistics also show us is that the more years that you go unmatched, the less likely you are to match in subsequent years. So we sort of steadily have this attrition. What the statistics lack are where those individuals now reside. I believe them to be spread out, throughout the United States, maybe in foreign nations, but I am certainly a product of that in some respects. There's no way of knowing how many of those are present Nevadans or how many will become Nevadans should this legislation go live. The other large swath of those that go unmatched are, of course, the international medical grads. That's largely what the FMG portion of this bill is, essentially trying to address. Those individuals only match about 51 to 52% of the time. So they're largely making up the about 9 to 10,000 that do not match annually. And they have an even less likelihood of matching when they attempt to match on subsequent occasions.
Great, thank you. I have some other questions, if I might. Thank you for that. Certainly when I graduated from medical school, match day was a big day. And in reference to your not matching in urology, we had about 4 students at the time apply for programs that were highly competitive, very common that you don't match. Ophthalmology was one of them, urology, as you mentioned. But all of those kids subsequently matched, but they matched with a one-year internship somewhere until they could reapply. So it's not uncommon that you don't match when you go to these real specific specialties and then you do an internship. So I appreciate that. What do you do in that 1 year if you don't match anywhere, especially for foreign med? I know many of folks that went to a foreign med and medical school couldn't get back in the United States in a residency program. So I can appreciate that. I want to actually address the bill on some specific sections, if I might, Madam Co-Chair.
That's fine. I know it's an extensive bill, so.
Okay. So I appreciate that on Section 5, you are now looking at removing in Section 5, number 2, the ability to have an unrestricted license. Because so you're taking that, striking that entirely, and at no time will they have an unrestricted license, to be clear.
Thank you so
That's
much.
accurate,
Fabian
correct.
Dagnate for the record. Yes, and the reason why we did that was because there are some sentiments that have resulted just in general of quality metrics and equating to the circumstances and the level of competency that we have established. And so we believed at this time that is the appropriate step. If we come back 5 years from now and we say, you know what, we have a lot of these international medical grads, they're doing great, they're passing these exams, let's reconsider the full licensure process, and we can do that. But this is just at this capacity for this particular section for the international medical graduates.
Thank you. Under Section 7, number A, you're looking at allowing them in family practice, peds, internal medicine, psychiatry, and OB-GYN. My concern with that is the practice in some of these, the OB-GYN in particular, where it potentially be doing C-section, surgical intervention, and wondering about, and I guess it would be up to the individual institute to give them privileges if they had hospital privileges somewhere. Are you anticipating that particular thing is a problem, or in other states have them been able to get that type of licensure and privileges for that full scope?
Thank you so much. I'll let Anthony weigh in on that as well. Fabian Dagnate for the record. So the request that we received from stakeholder feedback that was we wanted to consider the full continuum of what primary care entails. But Anthony, if you wanted to go ahead and share the knowledge of what other states have done as well.
Thank you again for this, and Anthony and Julie for the record as well. I apologize if I haven't done any of the formalities appropriately. This is absolutely my first committee hearing, so I appreciate your understanding. So Senator Titus, to your question, other states have not left the legislation as expansive as this section specifically. So we did believe it in our best interest to address all of the areas of primary care because some of those are largely overlooked in terms of just sort of allowing access into primary care, into family practice or outpatient internal medicine. We wanted to sort of expand that scope, but here is sort of the way that's dealt with in this legislation. The associate physician or associate osteopathic physician cannot practice beyond what is allowed of them in their collaborative practice agreement. So essentially their supervising physician has the responsibility to ensure that they have the abilities to do the types of services that they are allowing them to do pursuant to that license. That's very much akin to what you see with physician assistants who largely can practice in all practice areas, not just in primary care. So they have the same sort of learning curve. They practice pursuant to an agreement with a supervising physician. And if they're going to then get hospital privileges to assist in certain types of procedures in the hospital setting or in outpatient procedure, that is all basically at the whim of the supervising physician who's now overseeing and responsible for their care.
I'm going to go ahead and go to a couple other people from the panel here, and I'll come back to you, Dr. Titus, if that's okay. Senator Stone?
Thank you, Madam Vice Chair, and Senator Donate, thank you for working with me on this bill. I made it a campaign promise when I was running that we were going to deliver more healthcare professionals to not only the urban areas, but rural areas that I represent. To me, this is a very creative way to tap some of the brain power that we have in Nevada, whether they're graduates from our medical schools that can't be placed in residency programs, or graduates from foreign medical schools, Juarez Medical School, Guadalajara, or even in, I think in the Caribbean we have a school as well. So, and I think this is a win-win in comparison to Arizona, where it not only gives the applicants time to find a match, which we hope that they do, right? But it's also going to give them an opportunity to fill the gap in the underserved areas. So that's the difference between Arizona. And also, Anthony, I just want to say what a pleasure it's been to work with you. And for your first presentation before a Senate committee, and this is my 6th year doing this business, you did a fabulous job. And we just followed your progress through the bill easily, and I really appreciate you. So the associate physicians have 2-year terms. And the medical boards, whether it be the osteopathic board or the medical boards, can renew that. Are there any term limits? Can they just repetitively go back? Can the board say, no, you've been doing this 4 years, if you haven't got a residency, we're going to just cancel you? Or if they're doing a great job in the rural areas, practicing, as you would say, as a physician assistant, and they're happy with that, and they're not getting reassigned or matched to a residency program, could they actually make a living doing this in perpetuity until such time that they can find a residency?
Thank you so much, Senator Stone. I'll quickly answer that, and I'll let Anthony weigh in as well. I think that's part of the sentiments that you'll hear today in terms of whether they should be receiving an unrestricted license and what their efforts could look like in the rural areas. Again, our goal is to use the historically underserved definition that has been created in past legislation. We want these individuals to focus in the most highest risk, the communities that have been left behind, which is the rural communities and neighborhoods like North and East Las Vegas, where we don't have enough providers there.
Right.
And so, but Anthony, you can chime in as well.
No, I think it speaks to, first of all, thank you again, Senator Stone, for the sentiment. I greatly appreciate the positive reassurance. Nonetheless, I will beat myself up, in perpetuity about anything that I could have done differently. But what I will say to speak to your question is, the answer is yes. Right now, there is no, pathway to unrestricted licensure. There is the possibility for the medical school graduate who's serving as an associate physician to remain in this position in perpetuity, in this mid-level capacity, making the living as such, providing the care that's required, ensuring continuity of care, which is a huge health metric. there are other states that have gone the other direction. They have put time limits. Utah, I believe, has one. I spoke of Arizona's earlier. I believe the only state that does not have time limit on this capacity is Missouri. And of course, that's why I wanted to embody that legislation, because as I stated to Senator Titus, there's a possibility that these individuals will never match year over year.
Right.
The more you attempt, the more time that goes by, the less likely you match.
Well, thank you for those answers. And I want to refer us now, if we can, to Section 27 in your amendments where you strike G, which is basically the reporting that a associate physician would give to their mentor, if you will. And it basically says that those procedures are going to be dictated by the board. So you also state in the legislation that a provider can supervise no more than 3 associates. What if the board comes up with more comprehensive reporting than what you had originally proposed? Do you see that that ratio could be decreased based on more reporting requirements and more collaboration with the supervising physician?
I just wanted to make sure I didn't speak over Senator Doñate.
Please proceed. Yeah.
So Senator Stone, to your question, you'll see there's additional language in sort of subsection. Oh, I apologize. I'm getting some feedback. Can you hear me?
Yes.
We
Okay.
can hear you.
So, is that a yes?
Mm-hmm.
Okay, perfect. So subsection 1 of subsection G, maybe that's subparagraph, I'm unsure. But that is where I've made very clear that the procedures that the board adopts pursuant to the review of standard of care under the collaborative practice agreement may be no more restrictive than that which is required for the physician assistant. And my understanding of the requirements for physician assistants under the code is that we have granted sort of pretty minimal oversight in this area. But that's largely to allow physician assistants and supervising physicians to sort of meet the demand without putting this overwhelming burden on the supervising physician in terms of what they're required to review. And so that's the reason that it's worded as it is, to make sure that it doesn't go beyond what's expected of a physician assistant, who I believe this position to be analogous to. But it shouldn't add additional burden to the supervising physician, because that could be sort of contradictory or counterintuitive to what the expectation of this bill is.
Okay. And then just a final question, and I'll be done. I'm looking at the scope of services that are going to be provided. Dr. Titus, Senator Titus talked about her concern about the OBGYNs. I have just a little bit of an inkling about the psychiatric role. I know that to become a psychiatrist, it takes a number of years with intense one-on-one therapy with a psychiatrist professor. And here you've got a medical school graduate that may have done maybe a rotation in psychiatry. And I find it difficult that a mentor psychiatrist can oversee 3 students that have very little psychiatric training when you're dealing with very severe psychiatric issues such as, psychosis, etc. So can you give me your sense on how we can ensure that those that are delivering psychiatric services under the supervision of a psychiatrist can truly deliver state-of-the-art care in this very complicated part of the profession?
Yes. So I think something that's really important to point out to your question, specific to the psychiatric practice, Senator Stone, is Section 34. You'll see this in the amendments as well.
Mm-hmm.
There was this specific provision related to that exact sort of question. How do we ensure that not only the osteopathic physicians, but who are psychiatrists, but also the mid-level providers providing services under their license and pursuant to a collaborative practice agreement, how do we ensure the quality of care specific to that sort of the sensitivity of the subject matter, the populace, the sort of overwhelming vulnerability of the community that they're serving. And as you can see in Section 34, there are additional continuing medical education requirements specific to that area. But I think something to sort of put your mind at ease here, and it goes back to my response to Senator Titus in regard to OB/GYN services as well, is that one, a psychiatrist need not accept any associate physicians under their license. This is entirely sort of at their discretion if they can handle that capacity and if they feel like they have the ability to invest the time that's necessary to ensure that the associate physician is able to provide care that's commensurate with their levels in very specific areas. So they get to mold that relationship to ensure that they're not putting their patients at risk, while also allowing the associate physician who may want to practice in this realm the ability to do so.
Great. Thank you. I applaud you both for working on this legislation. I think this is going to be a model for the country if we can get it passed. So thank you again.
And I think it will go right back to Senator Titus.
Thank you. Thank you, Vice Chair, for letting me have another bite at this apple here. So I still have a couple more questions, actually. When you talk about in Section 12, you talk about relicensure or reapplying in 2 years. But there's no stipulation to that other than that they have no major issues, apparently. When I have to reapply for my license every 2 years, and under that application process for my license as an MD, I have a litany of courses and CME that I must take. Culture competency, understanding prescription drugs, suicide prevention, a whole list that have been mandated and so many hours that I must take. I don't really see that in this of any extra ongoing training they must have. Is that somewhere that I missed, or you didn't include that?
So, Senator, you are absolutely correct. That section may need to be sort of extended to incorporate those items, although the ones that I did designate earlier with Senator Stone, Section 34, for instance, in the osteopathic realm, NRS 633, there are a number of CME requirements, and I did factor the associate osteopathic physician into that, but I agree with you that that is something we will need to further delineate.
All right.
And Fabian, not for the record, we'll make sure to readdress that as well.
Great, thank you for that. And then, just as a personal bias, admittedly, I'm a residency-trained family practice doctor. I practice in my little family practice office by myself, 30 miles from the nearest healthcare facility. That would include any professional EMT folks that were trained other than a voluntary ambulance. So it was me. There was no other pharmacy, 30 miles in any direction. I had to know a lot about all the books, all the cases. I would have drive-by disasters all the time. Would actually go out into the fields, take care of folks. So my level of what I had to be competent in was pretty broad. I would brag that I actually had to know, the specialists have to know about one book. I had to know about all the books. And so I'm just a little concerned that you're putting somebody without that extra training out in the rural areas with a limited backup. And so I have some concerns with that. Although I have to tell you, and I shared this with Senator Donate, when I was in residency, and this was a long time ago, 1981 was when I graduated from medical school, so that 3-year family practice residency, I actually developed the rotations that I would take, knowing that I'd have to go back to my rural area and what the potential stuff I would have to see. So I chose to rotate with those doctors that went out to rural Nevada so that I could see what they would see. And then I would go back and take another month in whatever that happened to be, say orthopedics, those kind of things. And so I share that sometimes the best program is a true apprenticeship where you're working with another doctor. My concern is that it's one thing if that doc is right there. I had many residents rotate with me, and they got incredible skills by rotating with me and that hands-on experience. And so I'm not opposed to the mentorship, the apprenticeship, if somebody can't get in and match, but just to make sure that they can learn, and just putting somebody with minimal training, and like my colleague said, a month of their psychiatric rotation out in a rural area without that backup, I have concerns. The concept I like, the using trained folks that have that potential to go out there, but there's a lot of things that I think we need to have further discussions on before I can really get comfortable with this. I think I like the concept, but I just that worry about the training and how will they get that. I like the fact that they could maybe do an apprenticeship if they can't match in a residency, to have somebody like myself say, hey, come, I've trained so many folks in that, I would be comfortable having, come work with me for 2 years, and that kind of process. But would want to know that they were getting some mentorship and training, and at the end of the day, be able to pass that residency board. And at the end of the day, challenge a test. And if they could show that competency, then I would be, comfortable with that. So I'm going to get off my soapbox. That wasn't a question. I would just, I want to support it, but I have concerns that we're putting people in my rural areas with less than competent people because there's nobody else to be out there. And so, and it's not just islands and rural areas, but urban areas too. But in an urban area, I'd be more comfortable with this in an urban area, because right across the hallway, you could go see a specialist, you could go see a colleague. So I'd be much more comfortable if this was to use and say they couldn't go out to a rural area, that they had practice in an urban underserved area, because at least in an urban underserved area, you have help 5 minutes away or across a hall or very close. Whereas you put them out in a rural area where literally you don't have anybody right there to help you. And, that's where I'm more concerned. Urban-wise, there's lots of support there, but out in a desolate urban area, when you can't get a care flight to fly in, and it's you, and I've been there, you better be competent to do it.
Thank you so much, Senator Tice. Baby Nonyate, for the record. I hear a really good amendment idea that we both can work on, specifically to address the folks in the rural areas. We want to make sure that we can have more physicians there, and so I'll work with you on that part. And I think I have an idea as to how to solve that. So thank you so much for addressing that.
And I'm looking around to see if there are any other questions, and I don't see any. Amazing first presentation. While I'm sad that it sounds like we've lost you from our medical community, I hear that you have joined an amazing legal community. And I think it's good to have that kind of health policy background in the background too. So with that, I will go ahead and we can start with testimony in support of Senate Bill 204. I'd remind anyone to please state your name for the record before you speak and limit your testimony and your comments to 2 minutes. And I don't see anyone running up here to the podium. So I don't see anyone, and I don't think we're connected in Las Vegas. So broadcast services, if we can go to the phone.
If you would like to testify in support of SB 204, please press star 9 to take your place in the queue. Caller, please press star 6 to unmute yourself.
Hello, good evening. My name is Dr. Tiffany Ostavar-Kermani. I certainly appreciate all of you meeting and discussing this bill this evening. I did submit my written testimony, and I just certainly have to say I cheer all of you on for the efforts that you've made and the concerns that you brought to the audience. I am a resident of Texas, although I have absolutely no problem relocating myself for an opportunity such as this one. I want to just address a couple of the concerns that were brought forth, and with regards to how, I guess, competent a medical school graduate would be by saying that I personally had to attend an entire year additional to my medical school in New York, rotating in specialties including surgery, psychiatry, pediatrics, family medicine, internal medicine, and other areas. And I decided to rotate in infectious diseases because that was my interest then. I want to make sure we understand that medical school students, when they apply to residence or for their residency specialties, they have almost, they don't have as much as I would when I did apply. So I have an additional 1 year of clinical experience over even the most educated of medical students. No harm, no shade on them. But I have delivered babies. I have performed episiotomies. That was part of my curriculum as a graduate of my school. So I understand there's concerns that we would be pushing people, particularly out into rural areas with no support. However, the support would be there if we are supervised by a physician that is in that area. That is the actual impetus for us being mentored by yourselves. So you would be essentially our support as well as our teacher. Also, when you all apply for roles outside of the urban areas where you train, you may not necessarily have had as much experience as you do now as seasoned practitioners of medicine. So I did want to make that point. I certainly am more than willing, along with my other colleagues, to work with you and provide care to patients. And we are all quick learners. We've passed our exams, so I certainly think we are more than qualified to work in these roles. Thank you.
Thank you. If we can go to the next caller.
Hello, everyone. Can you hear me?
We can hear you. Go ahead.
Okay. First, I appreciate the opportunity to speak in this solemn session. My full name is Calvin Garcia Alfonso. I'm a Cuban doctor, and I'm currently enrolled into the nurse practitioner program. I am very honored to join yourself. I won't say my full curriculum because it will be so extensive. And I just want to say that I understand all the fears and all the concerns by putting non-experienced people working with patients and caring mainly OBGYN patients. And I just want to say that in this point we are doing that already by putting nurse practitioner without medical background and physician assistant with a shortage time of university training or medical training. I'm sorry. So we are already doing that, and they are fully licensed or they are fully permitted to practice that in different practices. Myself, as a medical assistant, because I have to, I had to be related to the medical field. By myself, I can experience that several times. I have to assist nurse practitioners who were working wrongly, who were misdiagnosing patients, and I have to support them, but being medical assistant. And I couldn't. Sometimes I couldn't do anything else beyond my scope because when I have 12 years of medical experience, I have to stay back in my scope as a medical assistant. And even I was fired in a couple of times just to be shadowing persons who were not confident in their own competency.
And sir, you've reached your 2 minutes. I would encourage you, if you want to submit your rest of your testimony in writing, to do so. And can you spell your name for the record?
Yeah, absolutely. Elvyn.
Thank you. And your first name?
That's my first name.
Oh, okay.
It's Kelvin. My last name is Garcia Alfonso.
Garcia. Thank you.
You're very welcome.
And if we can go to the next caller, if there is.
Hi, can you hear me?
We can hear you. Go ahead and state your name for the record and spell it, and go ahead when you're ready.
Sure. Hi, everyone. My name is Saideh, S-A-I-D-E-H, last name Nia, N-I-A. First, I would like to thank everyone who joined this great presentation. It's an awesome bill, and I'm in a full support of this bill. And the reason for it is, although my time has passed and my golden age has passed, I don't want anyone else to go through what I have gone through. We go through the great sacrifice to graduate from medical school, and for me to now teach medical assistant, to teach nursing and pre-med, to go to medical school, although I get a great pleasure and feel like that I'm helping someone, every day that I go to the class is a knife on my heart, because that's the golden age that I could have had. That's the golden age that I could have had now to give back to the community as a practice physician. So I don't want any of the medical grads who sacrificed their life to experience what I and many of us have experienced. So I'm in a full support of this. There are always flaws in any laws, but until the law is not, the bill is not practiced, it can't get to be perfect. So I hope that it does get passed to help the medical graduates who still have time to pursue their dream to do so. Thank you.
Thank you. And broadcast services, I'm not sure if we have another caller, but if we do, can we go to any callers in support?
There are no additional callers to testify at this time.
Thank you. And I can confirm that it looks like there is no one to testify in support in Las Vegas. And so at this time, we will now hear testimony in opposition of this bill. If you are in opposition to this bill, please make your way up to the microphones.
Good afternoon. My name is Sarah Watkins. I represent the Nevada State Medical Association. The Nevada State Medical Association opposes this bill as it would create a pathway that dismisses the tremendous value of postgraduate training, which in turn could create risks for patients and physicians. As a patient advocacy organization, we appreciate your attention to Nevada's healthcare provider shortage, and we share your goal of wanting to improve the state's access to care for all Nevadans. We believe the best path for those who have graduated medical school is to complete a residency. This isn't extra training, it's the foundational requirement for a doctor to be deemed clinically competent and safe to care for patients. Working to expand the GME residency opportunities in Nevada will be a more appropriate path for trainees who may find that they are not happy with their current residency program. We hope we can work with you to expand Nevada's GME and residency programs so that eventually all doctors who graduate from a Nevada school can find immediate placement in Nevada, should they want to stay here, and that we can attract the best and brightest graduates from medical schools throughout the country. We also understand that there is an amendment to this bill that we didn't get a chance to fully review as an association, and we are happy to work with the bill sponsors and to find ways to improve the access to high-quality care for Nevadans. Thank you for your time.
Thank you. I'm looking in Las Vegas. I don't see anyone in the room. And broadcast services, if we can go to the lines for any testimony in opposition.
If you would like to testify in opposition to Senate Bill 204, please press star 9 to take your place in the queue. Chair, there are no callers at this time.
Thank you. At this time, we will go to neutral testimony. If you can fill in, oh, it's going to be a big neutral day.
Thank you, Vice Chair. Elliot Mallon for the record. On behalf of the Nevada Osteopathic Medical Association, we are neutral on this bill. We appreciate the sponsor coming to us, working with us. We worked with him on the amendments. We're appreciative of that. We would also like to note that we agree on GME spots here in Nevada. That is vital for the future of our state. But as long as these doctors are in this pathway and they don't get full licensure, unrestricted licensure, without completing a residency, we're happy to stand in neutral and potentially in support. Thank you.
Dr. Barry Cole, Barrycole. I'm enthusiastically neutral on this, and I'm almost to the point of being passionately for it. I just need a few more tweaks. We're going to have a beer, I think. Doctor is a titular term because you've got a doctoral degree. Dr. Stone, Dr. Titus, Dr. Cole. We're all doctors. I get it. So letting them be called doctor, it's no different than a doctor of nurse practice is now called a doctor as well. I just learned this last night. One of my residents told me that at the University of Oklahoma last year, of his entire graduating medical class, a third didn't match. I had no idea it was that bad. It used to be that you could almost get a residency in anything if you looked around. Psychiatry has now completely filled up every year. There are no leftover spots in psychiatry. So definitely we need more residencies in psychiatry. This sounds like, at first blush, a bit of a decentralized residency program, and I think it's conceptually brilliant. I, too, started out in Guadalajara and then transferred to Wake Forest to complete my education. I would have been in the same boat as our previous caller had I stayed in Mexico doing a year fifth pathway, or else I would have had to do internship and servicio social for a year in Mexico to then start over an internship in the U.S. ER docs have no training in psychiatry whatsoever. 3 years of residency, not one rotation. When I was an ER moonlighting doc, I figured out right away every other person had a mental illness, it seemed to me. You don't run a lawnmower over your foot at 2 a.m. drunk because you're not having some illness. Medicine is perishable. If you don't use your skills, you lose them rapidly. So I applaud the effort of this to get more people practicing and to just figure out how to do it with all the guardrails in place so that everybody's safe. Thanks.
George Ross with Carrara, Nevada, on behalf of Touro University. Touro is neutral. Touro supports just about anything that would increase the supply of physicians in the state of Nevada, but this would be contingent on them not taking residency positions away from graduates of Nevada schools or slots from PAs educated in Nevada. Thank you.
Thank you, Madam Chair. Helen Foley for the record, and I am representing the Nevada Association of Health Plans. It's a statewide trade organization representing 10 member companies providing commercial health insurance and government programs to Nevadans. We thank you for the opportunity to testify in neutral. We're all very concerned about the healthcare work shortages plaguing our state, but have questions on how some of the processes will work with health plans currently. And how we will then work under this legislation. So we commit to work with the sponsor, Senator Doñate, and look forward to moving forward. Thanks.
Thank you, Madam Vice Chair. Tom Clark for the record. I'm here today on behalf of the Board of Medical Examiners, which has been mentioned quite a bit today. I want to thank Senator Doñate. He's been working with the senior staff at the Board of Medical Examiners long before the session even started, and has met with myself and with my other colleagues that represent the BME. And we are, learning a lot about this process. In fact, it was his work that caused the Board of Medical Examiners to put together a legislative subcommittee for the first time in its history to review these types of legislation. Unfortunately, it doesn't happen until tomorrow at noon. But I look forward to taking the bill, the testimony that was today, all of the amendments to that committee tomorrow, and have them deliberate. We look forward to working with Senator Doniate as we move this forward. There's one thing that is real, and that is the shortage of providers that we have in this state. And the Board of Medical Examiners does not want to be a barrier to that, but we do want to make sure that it's thoughtful and well-designed. Thank you, Madam Chair.
Good afternoon. Joan Hall, representing Nevada Rural Hospital Partners, those rural areas that Dr. Titus spoke of. We also have a great need, and we recognize the issues that Dr. Titus brought. Being 30 miles from anyone else to provide care is exactly what happens in rural Nevada. So that mentorship is very, very important, and a good nurse beside you is also very important. We want good care for our patients, and it is not excusable to lose this brain power because somebody didn't match with a residency. So look forward to meeting with Senator Donate more on this and getting to support. Thank you very much.
I don't see anyone else here in the room, and I don't see anyone in Las Vegas. Broadcast Services, is there anyone on the phone line in neutral?
Chair, there are no callers choosing to testify at this time.
Thank you. At this time, I'll turn it back over to you, Senator Donate. Do you have any closing remarks?
Thank you so much, Vice Chair Nguyen, and of course to the committee. Again, I think I want to end on just a few notes. I'm glad that you were able to hear the real life stories, not just Anthony's, but of the people that find themselves in this situation. Number one, I believe that supporting international medical graduates and obtaining a license to practice is a very good proposal that can help bridge the gap between what we discuss in health equity and the community. Let's be clear, a diverse medical society helps all of us, especially when we have the opportunity to uplift physicians that not only understand the cultural barriers of a community, but have also lived through it. I think that's something that can help reduce the disparities that we see in existence. And, with regard to associate physicians, this is a common sense solution that can attract more individuals to our state. Multiple states, as we have reiterated today, have enacted this legislation. It's not a new concept, and there's a reason why other states have succeeded. I will do my due part in making sure that we address some of the concerns that were documented today, and I would hope that we present that in the amendment before the bill, if it does get the chance to get work sessioned. And we know we also have to address the fiscal note that's attached to this bill, and so we have a few more strides to go, but we thank everyone that has weighed in on this issue, and we hope that, at the end of the day, we want to solve the physician shortages that we have in Nevada, and we firmly believe that this bill will improve the livelihoods of our community. So thank you so much for attending and letting us have this presentation today.
Thank you. And with that, we will close the hearing on Senate Bill 204, and I will turn this gavel back over to our chair.
Thank you so much, Vice Chair Nguyen. At this time, committee members, we will go ahead and move on to the last agenda item, which is our work session. So we have a few bills today that we will go ahead and work session. So as a reminder, we have Senate Bill 4, Senate Bill 43, and Senate Bill 44. We'll go each one individually, but I'll have at this time, I'll turn it over to our committee policy analyst, Ms. Destiny Cooper. So please proceed.
Thank you, Chair Donate. Destiny Cooper, committee policy analyst for the record. I cannot advocate or oppose anything that you will hear before the committee today. The work session document can be found at the table in the front, in the paper copy, and also on Nellis for your reference. And then with that being said, we'll move on to Senate Bill 4. Senate Bill 4 was heard on February 7th and is sponsored by Aging and Disability Services of the Department of Health and Human Services. It revises provisions governing certain programs to pay for prescription drugs, pharmaceutical services, and other benefits. The bill authorizes the Department of Health and Human Services to allocate money into contracts or intergovernmental agreements to cover the cost of prescription drugs and pharmaceutical services for those who have met the criteria for eligibility and are residents of Nevada. Additionally, this bill expands the eligibility criteria, replacing the language of senior citizens and persons with disabilities with natural persons who are residents of this state. That's the end. Thank you, Chair.
Thank you so much. Members of the committee, are there any questions or discussions on this bill? Seeing none, I'll go ahead and entertain a motion on do pass for Senate Bill 4.
I'd so move to do pass Senate Bill 4.
We have a motion from Vice Chair Nguyen. Do we have a second? We have a second from Senator Lang. Any discussion on the motion?
Yes,
Senator Titus.
thank you, Mr. Chair. I'm going to be a no on this bill. I'm concerned that these monies were from the tobacco fund. If anything, I think these funds should be more restricted on what we're using tobacco funds for. I'm worried that we're diluting what we can use the funds for and somewhat diluting the purpose of these funds initially. So unfortunately, have to be a no.
Thank you so much. Any other comments? At this time, we will go ahead and proceed with the vote on the motion. So all those in favor to do pass Senate Bill 4, please say aye. Aye. Any opposed?
Nay.
We have a nay from Senator Titus and Senator Stone. Motion carries. So I'll go ahead and assign this to Senator Nguyen, if you can, for the floor statement. At this time, let's go ahead and move on to Senate Bill 43. Ms. Cooper.
Thank you, Chair. Senate Bill 43 was heard on February 7th and makes various changes relating to services for aging persons and persons with disabilities, also sponsored by ADSD DHHS. Senate Bill 43 requires updates to the strategic plan for persons with disabilities as ADSD determines necessary. This bill also revises the duties of the Nevada Commission on Services for Persons with Disabilities, abolishing the previous 5-year strategic plan and now authorizing the Commission to develop a statewide plan to improve services to persons who are deaf, hard of hearing, or speech impaired. The bill revises the qualifications of 4 members of the Commission. That's the end. Thank you, Chair.
Thank you so much. Members of the committee, are there any questions? At this time, I will go ahead and entertain a motion on Senate Bill 43.
Also move to do pass Senate Bill 43.
Thank you so much. We have a motion from Vice Chair Nguyen. Do we have a second? We have a second from Senator Lang. Any discussions on the motion? Senator Titus.
Thank you, Mr. Chair. Unfortunately, I also have to be a no on this particular bill. I'm during the hearing, I made the comment that I'm concerned about the number of commissions that we already have, over 250 boards. We have difficulty filling these boards, and just hate to see another one. My real concern about this is creating further silos of all these entities when we really need one board that can encompass all these. And I'm just worried that we're kind of diluting what we're trying to do here. So unfortunately, I have to be a no.
Thank you so much. Any other comments from any other committee members? Seeing none, we'll go ahead and move on to the vote on the motion. So all those in favor, please say aye. Aye. Any opposed?
Nay.
We have a nay from Senator Titus and Senator Stone. Motion carries. I'll go ahead and assign this to Senator Lang, if you can, for the floor statement. Thank you so much. And last but not least, we have Senate Bill 44. Ms. Cooper, please proceed.
Thank you, Chair. Destiny Cooper for the record. Senate Bill 44 revises provisions related to dental and oral health care, sponsored by Division of Public and Behavioral Health, DHHS. This bill was heard on February 16th. Senate Bill 44 transfers the state dental health officer, the state program for oral health, the state public health dental hygienist, and the advisory committee from the Division of Healthcare Financing and Policy to the Department of Health and Human Services. This bill states that the state dental health officer may, but is not required, to hold a current license to practice dentistry in the state and eliminates the requirement to devote all of his or her time to the business. There was an amendment proposed by Julia Peak, Deputy Administrator, DPBH, DHHS, and proposes to amend Section 1B, page 3, line 5, and it is attached to the work session document. This amendment changes the language to reflect the state dental health officer must have completed the educational requirements of licensure and may meet the other requirements to hold current license to practice dentistry issues pursuant to Chapter 631 of Nevada Revised Statutes. Thank you, Chair.
Thank you so much. Members, do we have any questions? Senator Titus.
Not necessarily a question, but I am pleased to let you know I'm going to be supporting this. I actually appreciate the department's working with my concern that they have to be qualified to hold that position, and that if they actually are practicing on patients, they'll have a license. But this way, we can fill this position, and thank you for hearing my concerns. So I'll be a yes on this happily. I'll even second it.
Thank you so much, Senator Titus. At this time, if we don't have any other comments, I will go ahead and entertain a motion to amend and do pass.
I'll so move to amend and do pass.
We have a motion from Vice Chair Nguyen and a seconded from Senator Titus. Any discussions or comments? All those in favor, please say aye. Aye. Any opposed? Motion carries. I will go ahead and assign that floor statement to Senator Titus. So that concludes our work session for today. The last item on our agenda is our public comment. So at this time, we will go ahead and open public comment to anyone in this room. We don't have anyone here. Don't have anyone in Las Vegas. BPS, is there anyone virtually?
Chair, the lines are open and working, but there are no callers at this time.
Thank you so much. If there are any comments from members, I'll take them at this time. Seeing none, that concludes our meeting for today. Our next meeting will be on Tuesday, March 14th at 3:30 p.m. Meeting is adjourned. Thank you so much.